All right, guys, welcome back into the new part here, and there we go. So we've talked about a bunch of things. So this is the part where we put it all kind of together and have you actually interpret the 12 leads. Okay. And again, I'm going to be emphasizing a lot of points, but now I gave you the different pieces. So at this point, we're going to put all of those pieces together to fit into a congruent, how do I look and analyze the 12 lead, okay? So again, like I said, we're going to recognize and localize an AMI on the EKG and feel comfortable about interpreting a 12 lead. All right. So again, everybody knows the 12 lead. Everybody knows here. And one thing I'm going to circle here is the thing that we're going to really start looking at this point is this guy right here. Okay. Wow, white ink, Scott. Way to go. How about we go with some, I don't know, some red ink. Yeah. Here we go. That's what we're going to be really looking at really good. So again, that's what we're going to be looking for is that J point, that ST segment. Again, remember these are our waves. The Q wave is the one in the front. It's the first downward deflection. The S wave, of course, is the one that returns it back to is after the R wave. It's the upward deflection there. All right. So again, make sure that we Q waves are kind of a little bit important. The physiologic Q wave is usually always 0.4 seconds or 40 milliseconds. To be blunt, one little box. Okay, make it simple. All right. So pathologic is usually going to be greater than that. Okay. So again, we're talking about physiologic here. Okay. This one here, really wide, not okay. All right. So the QS complex, again, this is one of the patterns that can be formed, and we got to really be careful. Again, this is a normal thing that we can find, but it usually means there's some sort of damage. It's equivalent to a really wide Q wave, by the way. Okay, so just be aware of that. So your J point, again, it is the end of the QRS and the beginning of the ST segment, and this is where we're going to actually, we need to find out where this is. So if we're going to practice this, where are the J points here? Okay, on this guy right here, circle the J point. Again, circle your J points where you think the J point is. Okay, I think that the J points are in that particular spot. Okay, so let's practice a little bit more. J point again, right there, right here, and again right here. Okay. Now, the other thing is I would probably kind of start thinking, where's my isoelectric line at? Okay, that one's pretty easy, but look at the isoelectric line on this guy, and that's kind of actually I think play a little bit of importance here, because on this one here, was this an elevated ST segment? And I think that it was. So compare your ST segment to the end of the T wave and the beginning of the next P wave if you can. Okay, so it's one other way that you can tell. I prefer to kind of go off of the actual baseline and use your calibration wave to do that. All right, so if I take a look at this, all right, this one here, if I look at it, is it elevated? It's slurred up, but I wouldn't say that it's elevated. Versus this guy, I think that I have elevation compared to this segment here. Again, this one definitely elevated, without a doubt. This guy here, depression. Okay, this one here, not quite sure about that one. Okay, I think you may even have one little box there. Okay, and then if we look at this one, of course, the J point is way down here, and of course that's that one's depressed. That one's we're not really. That one's close enough to take a really good hard look. If I took a really good hard look, guys, I'd say that one's probably got 1 millimeter of elevation there. This guy right here is, of course, depressed. This guy right here, elevated. And this guy here was actually normal, okay? So he was flat. He was compared to that. So where do we find so how do I know if the person's having a heart attack? There's two things I need to know. What to look for and what are you looking at? Okay, where are you looking? And that's where that ISAL thing comes into play. You're looking for ST segment elevation, okay? 1 millimeter of elevation, one small box, in two or more contiguous leads, okay? In two anatomically contiguous leads, all right? And that's where that little chart about ISAL comes into play. All right, if we have ST segment elevation, we're going to presume that there's evidence of AMI. There are some mimickers out there, but I will tell you that the mimickers are really easy to spot, okay? And then the indications for acute reperfusion therapy. These are the folks that you take to the cath lab. Now, let's take a look at this guy. Now, we've kind of talked about ISAL already, so there's our calibration waves, looks good. Let's see here, progression of my R waves. Yep, we got good progression of my R waves. So far, so good. And I start circling some J points. Ooh, look at this. Ooh, look at that. Ooh, look at that. Oh, okay. Let's see here. I come over to here. Not really. Nope. 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 Actually, this one's kind of. If I circle that one because I know that it's abnormal, depressed, right? Matter of fact, I'll be honest with you guys. The way I kind of do it is I say, hey, it's a depression, okay? And we're just gonna. So again, I got an inferior lead, an inferior lead. I got an inferior lead. Hey, guess what? Yep, this guy's having a heart attack. Let's get him to the hospital. All right. Quick reminder of our leads here. Again, this is where you put the leads to get the correct diagnostic look. And this little lovely chart right here. If you haven't already started memorizing this, I would highly recommend that you do so. Again, this is how I'm going to know which are anatomically contiguous leads. Now, one little sidebar on this. Remember that these guys can actually go together as well, okay? And if you stop and think about it, remember that you got those two arteries that come off, right? You got your left and your right coronary artery, and then the circumflex goes around. Guys, this artery here feeds that same area of the heart, right? That's the V2 area, and over here is kind of the V3 area, and over here is kind of the V4 area. And there are little anastomes that come off. There's different branches of those arteries that go off to those regions. So you could have a smaller block in those areas. Okay. I will tell you that normally when you get, you're probably going to get 2, 3, and 4 all together. Most always are you're going to get 2, 3, and 4 together. Okay. So let's continue, shall we? So an inferior wall, again, 2, 3 AVF. It's looking at the bottom wall. This is where it's looking at. This is the damage that's going on, the bottom part of the heart. Remember that camera view. Remember, we're looking at, there is our camera view. It's coming from the left leg. The inferior wall, again, also, we're looking at the very bottom. This is from the back side of the heart, okay? So remember, you got two main arteries that feed this one, the bottom end of the left coronary artery and the circumflex artery from the back. But the big one is the right coronary artery that feeds that wall of the heart. It's the main pumping chamber of the heart, really. It and the lateral wall are pretty much your two biggest pumpers. So the upper laterals are your 1 and AVL, okay? And versus the lower laterals are the V5, V6. It's a little bit of different camera views. So if you can remember, this is lower, this is lower, this is upper, and that one's upper, but they're all lateral, okay? They're all lateral views of the heart, okay? So again, it's looking at the lateral wall of the heart, usually fed by the left coronary and the left circumflex artery. Now, these guys here, V3, V4, you're looking at the very front part of the heart, okay? Your two leads are right here. You're looking at that very front section of the heart. Remember, mostly supplied by the left coronary artery, the left anterior descending to be specific, and however high up that goes is where you're going to have the blockage there. Okay, so yes, this one very commonly extends up into this one right here. Okay, so along the sternal border is the V1 and V2. Think of that as a straight down look at the heart. So again, it's primarily fed by that left anterior descending. So let's do a little quality analysis here. Do you think that these guys go together a lot? I will tell you that depending on where the blockage is, if the blockage is way up here, yeah, you're going to get a 2 for 1, okay? If it's down here, you're probably going to get more of just the V3, V4, okay? So again, we use this to localize our AMI. Now, Scott, why does it make a difference? They got ST elevation. We just got to get them to the cath lab. except for, are the complications from these heart attacks very different? Let's do a little overlay here. SA node, AV node, SA node, AV node. So what might I expect with your anterior walls or your septal wall MIs? I would probably start expecting some sort of blocks, okay? As a matter of fact, you need to be highly suspect for those. For your lateral walls, your inferior walls, I would be looking for more of the ventricular tachycardias to occur, okay? Or a lot of cardiogenic shock, a lot of backup of fluid, okay? The inferior wall definitely is your backup of fluid. You're going to be losing a lot of your ventricular filling, okay? Because that's not pumping to the lungs, which is not bringing it back to the heart, which again is going to cause decreased ventricular filling, okay? And by the way, you're going to get a backup of fluid in all of these guys, okay? You're going to get a backup of fluid in all of these with an inferior wall. The lateral wall, again, the major squeeze of the heart, a lot of ventricular tachycardia with that are involved in that. Many PVCs, which ends up in having dysrhythmias. So knowing where the heart attack is occurring, yes, it pays dividends for us. It pays a lot of dividends for us because then we've got in our mind that this is what's going to happen to them, and if you've already thought about this and you're already prepared to how to treat that patient correctly. Now, what am I looking for? Again, 1 millimeter elevation, 2 or more contiguous leads, okay? And then use your pocket card as a reference, but I assure you, you're going to have it memorized in no time flat. So again, going back to that original EKG, look at that. I'm circling. Yep, and interesting. So I've got an inferior wall MI. By the way, do I give nitrates to this guy? Absolutely not. Why? Because there's been a definite show that when you kill these guys preload, that you actually affect the ventricular load, that you send them quickly into shock. If it's actually involving the right wall of the heart, which, by the way, 50% of these are going to affect the right wall of the heart. Remember, if we go back, we click back to this last slide. Again, if it's the right wall of the heart that's being affected, okay, that inferior wall, if it's being affected down here, guys, if you kill that right wall, you kill that filling, you kill the preload coming back into here, I assure you, they're going to get sick quickly. And matter of fact, when you give these guys nitrates, they die on you. All right, so let's do a little practice here. Let's see here. Again, I'm going to circle. Look at that. I got ST elevations. I got ST elevation. I got ST elevation. Actually, a little depression there. Let's see here. A little depression there. Okay. Now we'll talk about why I'm putting the arrows on the depressions. Okay, because there's going to be a part of this here in just a second that's going to make sense. So yeah, this guy's actually having an anterior wall MI. Okay. Matter of fact, I would say probably he's having a septal anterior. So again, he's got all 4 of these. And if I go back and I click on this, what part of the heart am I looking at? Again, I'm looking at all of that part of the heart. And so again, I probably got a high block somewhere up there. So what can I expect a lot of? A decrease in pumping and probably some type of electrical conduction problem. All right. So the evolution, again, usually the T wave becomes hyperacute. It peaks out, if you will. It becomes tall and peaked. And you might even think, well, maybe it's a little bit of hyperkalemia. Well, actually, if you stop and think about back to the physiology part, that might necessarily be true, okay? Because again, the cellular damage is releasing the potassium from inside the cell. So technically that's part of it. And it's important to understand that. But then your acute is when you start having, again, super early in the MI, within probably 30 to 40 minutes, this starts to develop, okay? You get the ST changes, all right? And then again, it's going to slowly progress upward. And by the way, the only difference between this one is now they've developed a Q wave, okay? Versus on this one, they didn't have a Q wave, now he develops a Q wave, okay? So again, he starts to develop that pathologic Q wave. And then the problem is that it usually goes back to normal, and actually you usually end up with a little bit of depression sometimes. But again, now they've got a pathologic Q wave, so that we don't really know when that happened, okay? So, something I've stressed since day one, moment one, since we started talking about 12 leads. 1,000%, just because they have a normal EKG does not mean that they're not having a heart attack, okay? So even if it comes back normal, it doesn't mean that they're actually in the clear, okay? Anybody having chest pain that you think is cardiac in nature needs to be evaluated by a physician, up to and including blood work and probably an echocardiogram to make sure that they're pumping correctly. All right, let's do a little practice here. Let's see here. Find the J point. Yep, that one looks bad. Yeah, that one looks bad. That one looks bad. Did I see any depressions in there? No, that one kind of looks bad though. Good enough for me. Let's see here. How about this one? It's starting to flatten out, but we'll call that right? But long and short, we got the septal wall, we got the anterior wall, we got probably starting to get part of the lateral wall. Yeah, good enough for me. I would say, yeah, it's time to wake up somebody. Let's see here. Depression. Let's see here. A little bit of depression. A little bit of elevation. A little bit of elevation. Definitely elevation. Definitely elevation. Definitely elevation. Let's about one. All right. So yeah, this is a anterior lateral wall MI. So the good news is, guys, you can mix and match those words, anterior lateral MI, and stop and think about it. And we go back to here. Are they affected by the same artery? And again, remember, you only got 3 really to choose from as far as, so if you got a really high block up here, is it possible to get this guy, all of this area here, to be damaged? Absolutely. It is very, very possible for that to happen. Let's see here. Oh, yeah, 2-3 AVF, baby. Yep, that's an inferior wall. Break out the 15 lead. That's what we're going to do. Look at that. Depressions, depressions, depressions. Now, there's a reason why I'm pointing those out to you guys. All right. It's called reciprocal changes. And that's the reason why. It's very important to understand reciprocal changes. All right. And the reason that you want to find that, you want to understand that. So this guy's taking the picture from this direction. I have depression. I have the elevation here. But if I look at it from the opposite viewpoint, right, it's going against it. It's going to go farther. This guy flips upside down. Okay. So where this guy has elevations, this guy has depressions. Oh, wait a minute. Let's go back to here. So this one was looking at the lateral wall, all right? So if I draw my little heart up here, it was looking this way, right? And then the inferior wall is looking from this way, all right? So at this point, it's seeing damage down here. So on the other side, that means it was showing the depressions. It is a confirmatory finding for what we have going on. Now, are we going to get some EKGs where I see a bunch of depressions and I don't see elevations? The answer to that is yes. If I have somebody with an older heart attack, can it show as a depression? Yes, it can. But again, remember that a reciprocal change is just that, okay? Where you might have it where 2-3 and AVF was one, the other side, one AVL and the V leads, they teeter-totter off of each other, okay? So when one's elevated, the other one's depressed, okay? And then you got to understand that little concept. So again, I look at this one. Here, wow, 2-3 AVF. Hey, look at this. Those are the opposite end of the teeter-totter here, okay? Good news is it didn't spread to 5 and 6, okay? But again, I've got an inferior wall MI, okay? There's no doubt about it. I've got a confirmation via the reciprocal changes at this point. All right. Now, if I keep practicing here, oh wow, yeah, look at that. And by the way, notice depression. Okay, ooh, elevation there, right? elevation, elevation, oh, depression. But if we do the teeter-totter, right, that the different parts of the heart that it's looking at, you're right. I'm going to see those changes. Oh, elevation, elevation. Oh, definitely elevation. Okay. So I've got confirmatory reciprocal changes along with massive amounts of elevation. Now, you don't have to have those to presume an infarction, but if I'm seeing strong evidence of that, again, I'm thinking that, hey, we've got a but it's strong evidence if you have a reciprocal changes. All right. So when do you acquire your 12 lead? I am a firm advocate of you need to be acquiring it as soon as you possibly can. Okay. Especially if they're telling you, hey, I got chest pain. That's like a kind of an automatic. Okay. So get your and then start your treatment again. We greet everybody with Mona, right? Again, morphine or fentanyl for the pain relief. Usually we start off with oxygen. We give them some aspirin, and again, nitroglycerin if it is indicated. Okay, inferior walls. I kind of want to stay away from it. I don't start that part of my treatment until I have this right here. There is absolutely no way. Okay, because again, if I'm going to have, I know that I'm going to have compromise. Do I really want to kill, by giving morphine or fentanyl, kill that preload coming back into the heart? Absolutely not. I might need to give them a liter of saline before I actually start my treatment based upon what I find on the 12 lead. If I've got an inferior wall MI, actually, I'm going to take it a step further to make sure that I don't have any right wall or back wall involvement. Now, again, I'm going to save that one for a different video because that's the 15 lead, and it's very, very important that you learn how to do that, okay? But we're going to talk about that when it gets there. So, again, I think I'm going to... All right, I am going to leave it off of here because we're going to start how we're going to treat this and the anatomy and the findings and how we're going to deal with those on the next video. So I'll see you then, guys.